It gives me great pleasure to call on Dr. Rüdiger Krech, who is the Director of Health Systems and Innovation in the Office of the Assistant Director General of WHO, to come and give us an opening address entitled Universal Health Coverage as a Means to Increase Vaccination Coverage. Dr. Krech needs no introduction, so over to you, Rüdiger.
Thank you very much, ladies and gentlemen, colleagues, friends, dear Letizia, Bettina, and Marta. Thank you very much to the World Federation of Public Health Associations for organizing this event. Looking at immunization and the role of universal health coverage can reveal important lessons how we need to strengthen health systems. My colleague Richard Muzoko was killed on the 19th of April while he was fighting the Ebola epidemic in Butembo. A militia group entered the university hospital and opened the fire during a coordination meeting. And while we strongly condemn this deed, and while we are in grief about our colleague, and while we appeal to the world that attacks on health workers need to stop, we can also ask, what the heck is going on? What is going on during a fight of one of the world's deadliest diseases, where people just try to get the job done, where the goal is to save the infected, prevent the disease to spread, and cut the transmission chain, where there is safe and efficacious vaccine. We had to learn it the hard way in 2015, and I believe that we can all learn from this experience in DRC for our theme today, which is that how access to needed health service without facing financial hardship will increase vaccination coverage. And I think that this is also a way how to put the global charter of the public health into action, especially in the area of prevention. Families didn't let Ebola teams take their infected relatives to treatment centers. People fled from quarantine, from these strange people in astronaut suits. People didn't comply with safe burial rules. People hid from contact tracers. In short, they didn't trust the people that wanted to help. It took some time to understand that we treated people more like bioagents than citizens. When we started to listen to the communities, their chiefs, their religious leaders, when we started to listen to their stories, their beliefs, their will, when we then talked about the disease, the risks, our beliefs, our fears, when we then developed options together with the citizens how to act in this situation, what to do, that was when people started to work with us and not against us. The magic word was trust. And now Ebola is back in the DRC. Today, the situation is much different from 2015. Today, we have a very effective vaccine against Ebola. And by the way, WHO's played quite an important role in this, and I guess that without the coordinating role of WHO, we wouldn't have this vaccine. Indeed, a rapid international response has managed to stop the spread in a string of towns, including Beni, Kiondo, Komanda, Chomia, Mabaloko, Mandima, and Kanya. But in two towns, Butembo and Katwa, there has still and has been persistent infection and reinfection. Why was that, or why is this? 1 in 4 people in these two towns told researchers that they don't believe believe that Ebola is real and that therefore they don't want to be vaccinated. They are confused that suddenly there are all these health centers and materials and cars where nobody before had actually invested in what they needed. They say that it is interesting that Ebola started in North Kivu, where protests against the current government is harshest. This area is struck by violence. People as close as 5 kilometers from their village are regarded as outsiders. People one would not trust. There are many militia groups, at least 21, around Butembo and Katwa. There is a lot of political gaming going on by government, the opposition, and others. The community engagement strategy involved health workers visiting a village in advance of vaccination, but by the time they went back the next morning or afternoon, youth groups or others were often there to intercept them. It's this time not the families who are rejecting. It's other elements in the community who have been organized to respond to these outsiders, be they government or NGOs or others, and that has caused a lot of flashpoints with the teams. So the problem is totally different from attacks on health facilities by armed insurgents who had used heavy arms fire, rocket-propelled grenades and other stuff which had horrified local inhabitants. To try to improve access for health workers, there have been discussions with Congo's president and opposition leaders, as well as with the Bishop of Butembo, imams and tribal chiefs who wield political influence. But a truly all-society approach is needed, or this situation will get even worse. I'm telling you this as the lesson learned from the Ebola crisis in 2015 was that integrating the prevention of an epidemic into health systems that are built on community engagement and trust is key. The lesson from 2019 is that this is not enough. Health systems need to be part of the insiders, trusted by the locals and protected by the whole of society as a common good. The lessons for those working on strengthening health systems in countries is, it is not just the building blocks of health systems. The starting point of health systems performance must be how the delivery of health services meets the demands of people. This sounds simple. But if we look at this in this way, this has huge implications how we program external aid, how we plan disease-specific interventions, how we disseminate the resources, and how we reach those hard to reach in terms of vaccination. And what does this lesson mean for the vaccination and immunization for the rest of the world? In 2017, the number of children immunized, 116.22 million, was the highest ever reported. Since 2018, 113 countries have introduced new vaccines and more than 20 million additional children have been vaccinated. That's good news. But despite gains, all the targets for disease elimination, including measles, rubella, and maternal and neonatal tetanus, are behind schedule. And over the last 2 years, the world has seen multiple outbreaks of measles, diphtheria, and various other vaccine-preventable diseases. Most of the children missing out are those living in the poorest, marginalized, and conflict-affected communities. In industrialized countries, many people are concerned about potential side effects of vaccines. Let me give you the example of measles in Europe. Since 1st of January 2018, 47 of the 53 countries in the region have together reported over 100,000 measles cases and over 90 measles-related deaths. due to the persistence of pockets of non-immunized or under-immunized individuals in many countries, fueling the continuing spread of measles. The reasons for this rise are complex, and not all of these cases are due to vaccine hesitancy. However, some countries that are close to eliminating the disease have seen a resurgence. Immunization hesitance is one of the 10 biggest threats to global health in 2019. The reasons why people choose not to vaccinate are complex. A vaccines advisory group of WHO identified complacency, inconvenience in accessing vaccines, and lack of confidence that are as key reasons underlying hesitancy. So, in vaccine coverage, we've reached a plateau, and we will discuss what this means in the individual diseases. But what I would like to look at from the health system's point of view is that when I just talked about that health systems need to be part of the insiders, trusted by the locals and protected by the whole of society as a common good, this is not confined to fragile states or developing countries. Anti-vaxxers are a quite vocal group, for instance in the country where I come from, which is Germany. Also here, health workers, especially those in communities, need to remain or need to become the most trusted advisor and influencer of vaccination decisions, and they must be supported to provide trusted, credible information on vaccines. And that, I believe, is one of the major tools and instruments how we reach the unreached so far, and how to put the global charter of the public health of the World Federation of Public Health Associations, which we as WHO are very much aligned with, will be put into action. This will strengthen health systems and while contribute to higher immunization rates at the same time. I thank you.
Hi Rüdiger, thanks for an excellent presentation. I'm Dr. Joe, nurse, and have been involved in developing the Charter for the Public's Health in the past and very passionate about it. Quick question. There's a lot of reform happening in the WHO, and I'm really pleased to see universal health coverage is sort of across the different divisions much more, and that's excellent. Where does public health fit in that, and therefore the sort of vaccination work? Thank you.
Good morning. Thank you very much for the opening presentation. It was very insightful. My name is Dr. Jane Barrett. I'm the Secretary General of the International Federation on Ageing. I'm struck in the opening comments that there is very little conversation or even notation about adult vaccination. I think this really, is a very important conversation that needs to be part of a life course approach to vaccination. So I would be very interested in your comments, sir, about where older people and adults fit into this conversation about vaccinations today.
Good morning, my name is Thomas Hausmann, I'm a medical student. My take-home message from your great speech, thank you, were that we need to listen and that healthcare workers are key if you want to reach the hesitant population. So my question is, do we teach future healthcare workers to actually listen when it comes to vaccines?
Yeah, Bettina Borisch. Rüdiger, thank you so much. Simple question, but difficult to answer. What are the best ways to re-establish trust when it got lost?
Rüdiger, over to you. Very tough set of questions.
Very good. Thank you very much. Very good questions. First of all, Joe, about public health and where it fits in this whole issue of universal health coverage. Well, essential public health functions are part of universal health coverage and are intrinsic part of health systems. That's exactly what we are really fighting for in this transformation, because by artificially separating public health functions from health service delivery, we're creating parallel structures where there's a lot of inefficiencies in the end and a lot of more costs attached to it. So therefore, within the Secretariat itself, but also in our technical assistance to member states, we strongly advise to firmly build essential public health functions within the health systems and not parallel structures. Now, we could discuss more in length about the donor community and how the donor community, which only represents 1% of global public health spending, but has a huge impact on the global discourse, how that actually affects vertical programs where we need to overcome that and not start establishing specific public health functions for, let's say, malaria or tuberculosis. But to integrate those into the ongoing national health systems. So that's one of the parts. So it's not just how we are structuring ourselves within the Secretariat of WHO, but also how the overall donor community responds to it and how national governments set up and evolve their health systems overall. The second question on the life course. Thank you so much for it, and indeed I should have alluded to that. And that's also in parts covering the restructuring in the Secretariat of WHO, because we are now together with all the life course, all the population-specific interventions in universal health coverage, and that is exactly why, because we see that, for instance, the immunization issue needs to be looked at from a life course perspective, right? So if you're not vaccinating children who then are not covered in times of adolescence, that's a big issue. So how does this affect your question, aging populations and older people? Indeed, we see that vaccination coverage in older people needs to be increased in all countries. And how do we do that? If then these people were not used to be vaccinated early on, right? So there's a big issue there where we need to do a lot of more capacity development, especially with health workers, so that they reach out to population groups of all ages actually, but including older age groups. So that is something that we need to much more look at. How does immunization coverage, how is it seen over the life course overall? So thank you for that question, and we'll take this up in the strategy and the immunization strategy that we're about to develop. The first zero draft has been posted on the internet, and we would welcome comments to that strategy. So that could be one very specific comment to that strategy. So thank you again for that question. Thomas, yes. How do we actually integrate listening into medical and nursing curricula and health professionals overall? I do believe that listening more, and that's an art, it's not just to be quiet and just to let people speak, but to really listen and understand what the other is saying. That's an art, and that's a skill that we usually don't teach in schools, in universities. And we need to do that much more. That's why together with the World Federation of Public Health Associations and the International Association of National Public Health Institutes and the regional associations like ASFAR, we're trying to look at what are the needed skills and capacities of health workers in the future, where do we actually can place them, and what are the needs in national institutions for that capacity, and how could we then include that also in the curricula for future education, so that we have the future fit-for-purpose workforce that we need. So therefore, thank you very much for that question, and listening is definitely part of that. And finally, Bettina, what are the best ways to re-establish trust? Now, trust is something very special, isn't it? It takes such a long time to build it up, and then it's so easily destroyed. It's like a gas that evaporates. All of a sudden, you think, oh, this person has misled me, and then all the 20 years before don't count. And that is something that we need to consider when we actually look at emergencies, in the preparedness of emergencies, and the role of health systems therein, and obviously also in the response and in the aftermath. So lots of trust that used to be in the Ebola-affected countries in 2014-15, where health systems were already fragile, like in Guinea. If you look at 20 years back, the Guinean health system was weak but not fragile. They had trust, they had community involvement, they had quality assurance, and that then was threatened by social upheavals, but also through vertical funds that actually have withdrawn health personnel from the overall systems into disease-specific programs, such as AIDS hospitals or so. So a lot of that was challenged, and then when the crisis hit the country, nobody trusted the health workers. So how do we build up this trust thereafter? It's really, what I try to say is becoming an insider, becoming part of the very close community in which you're actually serving your people. And to be engaged not only in disease questions, but also in the causes of these diseases. Be an active community member where you actually look at the issues that happen in the community from a health perspective, obviously, but where you engage with the people, their needs, their wishes, but also their beliefs. If you are part of that inside a community, you will gain much more trust. And therefore, this is not something that you can parachute in and then do something with whatever great campaign, but you need to be there and stay with the people through the good things and the bad things, and that is how you build up trust. Thank you very much.